Alrighty, well, good afternoon and welcome everybody. Thank you for joining us today. My name is Andrew Doffney. I'm the Instruction and Outreach Librarian at the New Jersey State Library. And it is my pleasure to present our speaker today, Dr. Khawaja, who is a fellowship-trained rheumatologist who diagnoses and treats diseases and systemic autoimmune conditions that affect the joints, muscles, blood vessels, and bones. She completed her undergraduate training with honors from Temple University. After receiving her medical degree at West Virginia School of Osteopathic Medicine, Dr. Khawaja completed her internal medicine residency at Lehigh Valley Health Network in Allentown, Pennsylvania. She later completed her rheumatology fellowship training at Georgetown University Hospital in Washington, D.C., and she also provided care for patients at the Washington, D.C. Veterans Affairs Medical Center during her training. So welcome, Dr. Karaja. It's been a few years since we have you speak here, but we're really glad to have you back. And before we jump into your presentation, I just have a few housekeeping items to go over. First and foremost, we will be taking your questions today at the end of her presentation, but please feel free to submit them anytime using the Q&A or the chat feature in the Zoom dashboard. There will be a survey available at the end of the webinar, so if you have time, we ask you please complete the survey. We really appreciate any and all feedback that you can give us. And if you want more information about arthritis and treatment and maybe some other things that Dr. Kawaja cannot get into today, you can visit arthritis.org for the Arthritis Foundation. They do fantastic work and have a lot of great resources on their website, so I encourage you to check that out at your leisure. And then one last thing, I just want to do a brief overview of the Zoom dashboard. This is what your dashboard should look like if you're using a PC or a Mac. If you're using a mobile device, the dashboard might look a little bit different, but all the features will still be there. In the bottom left-hand corner, you can check your audio settings. So if you're using an external listening device, like a headset or earbuds, you can check to make sure it's connected properly there. At any point during the presentation, if you have any issues, there is a raise hand button here in the middle. You can click on that and that'll alert me. I will send you a message in Zoom and hopefully be able to resolve any problems that you are having. Then, as I said, if you have any questions, you can use the Q&A or the chat buttons. Either one will get in touch with us and we'll address them at the end of Dr. Kawaja's presentation. So that is everything that I have for you. So it's my pleasure now to turn it over to Dr. Kawaja.
Thank you so much, Andrew. I'll go ahead and share my PowerPoints now. Hi, good afternoon, everyone. Thank you so much for having me today. I really enjoyed giving this presentation. I gave it a few years back, and I had so many great responses and questions regarding arthritis, which I'd love to share more information about today. So we will be discussing the variety of different arthritic conditions. There are so many different arthritic conditions to cover. So really today I'll be focusing on the main types of arthritis that I see in my clinic and hopefully shed some light on some of these different conditions. So we will be discussing osteoarthritis, which is one of the most common causes of joint pain, gout and pseudogout, polymyalgia rheumatica, rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, and Lyme disease. I will also be focusing on different treatment options for each and when it's a good time to see a rheumatologist. And then I'll also briefly share online resources that are very helpful to discuss arthritic conditions. So what is arthritis? So this is a very common question that I get. Oftentimes when you might hear your family and friends mention that they have arthritis, it could mean anything. There's over 100 different types of arthritic conditions. And what it refers to is different syndromes or conditions that can cause joint pain. So it's not just one disease, even though you might hear once again, family members say that they have arthritis, but it can mean a variety of different types of diseases. Unfortunately, it's one of the leading causes of disability. And common arthritis joint symptoms include joint pain, joint swelling, stiffness, and a decreased range of motion. So osteoarthritis, once again, is the most common cause of joint pain. I especially see this in my patients that are middle-aged or elderly. It's estimated to be affecting roughly over 300 million people worldwide, but it's probably even more than these estimated rates. I usually tell my patients that almost 70 to 80% of patients will have sorry, my apologies, over 70 to 80% of people will have osteoarthritic changes and pain at some point in their life. It's oftentimes referred to as wear and tear. However, it can mean so much more than that. And I really try to shy away from that a label, mainly because sometimes it can be confusing of should I be still walking or staying active with osteoarthritis, which most patients absolutely should. But it really involves a variety of different things that are going on at a microscopic level. What happens, this is a really good picture to show just what a joint looks like. So that's where two bones are meeting. There's a whole joint capsule. We can see just a diagram of the muscles, the tendons, the cartilage that's involved. And there are different types of cartilage that make up a joint space. But what happens with osteoarthritis is unfortunately the cartilage starts to wear off. The joint space starts to diminish, and then ligaments can also be affected at that point. And unfortunately, there can be bony spurs that can occur that can cause pain and once again help us establish a diagnosis of osteoarthritis. Most common areas that are involved are classically the hand joints, and I'll have a few pictures to show exactly what area of the hand is involved. Knees are very common, the lower spine, hips, and also the great toe. Osteoarthritis, however, can affect even more different areas than the ones listed. So it's always on my differential when a patient comes in and they mention joint pain, stiffness, and some degree of swelling. The most common symptoms that patients mention are joint pain. It might be something that was, slowly starting to present, or oftentimes patients will have flare-ups of pain. It can vary with weather changes. Most patients will say they have brief morning stiffness. That's really important for me to tease out. And usually when I mention stiffness, what I really mean by that, when I have a patient, in my office and we are going over their clinical presentation, I always try to tease out stiffness because that helps me differentiate the other types of arthritis. So stiffness, what I mean by that is almost, patients will say, Doc, I have to like defrost in the morning to get myself moving. So that's how it describes stiffness. So it's more than just pain. And typically for patients that have osteoarthritis, that stiffness will last anywhere from 15 to roughly 30 minutes. If it's more pronounced than that, then I really start thinking about other types of arthritis. Oftentimes patients will also describe like a gelling phenomenon. It almost feels like, when they almost have like a brick on their joint, and they especially notice pain, for example, from going from a seated to a standing position. And unfortunately, this can really result in many limitations going up and down the stairs or carrying out daily activities. Risk factors for osteoarthritis are older age, having family members with osteoarthritis. There is some sorts of genetic predisposition to getting it in some patients a little bit sooner. Obesity, previous traumatic injury or repetitive use. So oftentimes for my patients that were athletes, they may have more, for example, knee pain or lower back pain. And then joint deformities can also cause worsening changes related to osteoarthritis, and that's if, for example, if someone has one leg that's shorter than the other, or have knock knees or bow-legged changes. So here is a classic two pictures of hand osteoarthritis. So I oftentimes will get referrals for patients that have hand pain, and there will be a question of what kind of arthritis is this? Is this rheumatoid arthritis? Or I have patients that say their grandma's hands look like this, and they're really worried about having these changes. So classically, osteoarthritis, once again, these changes happen over time. And they may not always cause pain, but these are very classic findings, once again, of osteoarthritic changes. So on the left, as you can see on that joint, that's called a DIP joint. And there's a big bump on that. And what we call that is a Heberdine's nodes. So that's a major bone spur that has happened at that joint. On the right, you can see something called a Bouchard's node, which is also a bone spur that happens at that level of that joint, which is called a PIP joint. So when I see these bony changes, it's very suggestive that a patient has osteoarthritis. Another common area in the hand is right at the base of the thumb. And this is, we call this the CMC joint. And as you can see where the arrow is pointing, there's a bump, as that area should be really nice and smooth. So if you're having pain, especially grasping things, sometimes it can be related to either the CMC joint or STT joint, which is a few other bones that are involved in the hand, and they can all, once again, present with pain and difficulty holding objects or carrying things. And then classically, it's these bumps that we see that tells us that there's bone spurs. Here is an x-ray of, on the left, of a normal knee, which I'll point out a few different things. Okay, it looks like my mouse is working. So on the left, you can see kind of like, I'm not going to go into too much, but just a nice smooth contour of the joint. You can kind of make out the space. I can go ahead and put my mouse and trace it along the way. So this is the whole joint space. And then over here on the right, these are very classic radiographic changes of osteoarthritis. When my patients ask me, Doc, how can you be sure this is osteo? Not all arthritic conditions cause these changes. So these are like the classic things that I look for, which is bone spurs. So as you can see here, in comparison to this side, you have this extra bone spur right here. There's narrowing of the joint space. So this is what a lot of people might refer to if you have, once again, family that say they have bone on bone changes. It's literally that, which is the cartilage, unfortunately, is wearing off and the joint space is significantly narrowed. There's a few other features that tell me that this x-ray is very suggestive of osteoarthritis, which is there's a cyst in this area. We call them subchondral cysts. And what lastly you can see right over here is there's extra, what I call, it looks bright. We call it sclerosis medically. All of this is very suggestive of, once again, osteoarthritis radiographically. Here are a couple different views. So when patients that tell me that, Doc, I'm having a lot of pain going up and down the stairs, I always think about the kneecap joint, and that's called the patella, which we can see it looks very nice and healthy on this left side. On the right side for this x-ray view, you can see that it's starting to shift laterally and there's narrowing of that joint space. So this is usually called patellofemoral osteoarthritis. So treatment options, so there's a variety of different things that we can do to help alleviate this pain. The most important one is staying active. I cannot emphasize this enough, because one of the things that we can do to offset the pain is build really strong muscles to help alleviate the joint changes that are happening. So physical therapy, strength training are really important as we all age. For hand pain, I oftentimes will recommend first conservative options, which is heat therapy, paraffin wax. We can also do localized steroid injections, which might alleviate the pain. At least our goal is for a few months, if not several months. There's topical creams that are out there. One in particular is called Voltaren, which is diclofenac. This is a topical anti-inflammatory, which can also help at least offset the pain. And then different oral medications that we can discuss or use are Tylenol. I oftentimes recommend taking Tylenol arthritis, which is probably the safest oral medication. And then we use different anti-inflammatories. That's things like Advil and Aleve that can help. But I'm very weary if patients have to take it long-term, because long-term use can have complications. So we really recommend using them with caution. And then other times I actually use medications that might help with nerve pain, but they also, once again, can help with joint pain. So that's things like duloxetine or Cymbalta. And then lastly, if patients are having such significant symptoms or they're unable to carry out their day-to-day activities, it's at that time that I may consider recommending orthopedic consult for a potential surgery. And a lot of our patients that, that need it, they do really well overall, because, they've made so many strides in surgery, and most people tend to recover well, but it's all, a shared decision that we make together as a team. So once again, just home exercises are really important. I unfortunately don't have my list of YouTube pages that I recommend. There's quite a lot of physical therapists that have videos on YouTube that are all free, that are great for osteoarthritic joint pain, which I'm happy to send over if anyone would like later. The next condition that I want to talk about is gout. So gout is also a type of arthritis, and it's actually the most common cause of what we call an inflammatory arthritis. So osteoarthritis is what we call a non-inflammatory arthritis. Gout and many of the other uh, diseases that I'll be talking about today are considered inflammatory arthritis. So they cause a true inflammation response in our body that cause pain and stiffness and swelling. So gout affects over 3.9% of Americans, which ends up being approximately 8.3 million people. Probably still an underestimate, in my opinion. And what happens in gout is there's actual crystals that start depositing in the joints and soft tissues that cause exquisite pain. The prevalence is greater in men than women, but I oftentimes can see it in both males and females. And patients with gout have shown to have an increased risk of cardiovascular disease. So even though I'm treating joint pain, I always love to emphasize that it's really important for us to get that controlled because long-term inflammation is not good for our body in general, especially for our cardiovascular health. So when we get gout controlled, there's been significant data that we also lower risk for things like heart attack and stroke. So symptoms of gout include a redness, warmth, swelling, and oftentimes it's intermittent episodes. So there could be something such as like an acute patients have an acute infection, and then they end up having like a really swollen toe, or they eat something, and that might cause a gout flare. But it's all these different signs of inflammation that I really want everyone to focus on. So think of it as, exquisite redness, very warm, swollen joint. And it'll happen oftentimes acutely. So different areas that can be involved include, most commonly, I'm sure most people, excuse me, I'm just getting a page. Most commonly, I'm sure you've if you hear of someone who's had gout, they'll talk about their great toe being affected. But gout can actually affect a variety of different joints and soft tissue. So aside from the great toe, it can affect the other toes, the midfoot, ankle, knee, the wrist, elbow. It's very common to see almost everywhere. Uncommon sites include hips and lower back. So those are two areas that gout usually does not affect. But anywhere else, unfortunately, can cause a flare. So here are a couple of different pictures. And as you can see, this is even from the pictures, it's a true inflammatory response. You can see on this picture of the great toe of how red, swollen, and most likely this, patient was having exquisite pain. And it gets to the point where, unfortunately, some patients will say that they're unable to even put like a cloth or get their socks on or get their clothes on because of how painful it is. On here, you can see a really swollen knee. Oftentimes for these patients, we recommend actually taking the fluid out if it's really swollen, as that can really alleviate the symptoms, which I'll go into. And this is a picture that I always love to show because it always shocks my audience of, when gout is very severe and uncontrolled and untreated for many years, patients can have what we call tophi, and it can be seen in a variety of different parts of the body. So I always even check the ear, and I've had many patients, especially when I used to work in the VA, where they had tophi. So this is actually gout affecting the ear. And then this is a tophi here in the finger, and this is what we call olecranon bursitis. So this swelling is all related to gout crystals. So the way that we diagnose it is we have a myriad of different tests that we do. Most commonly, we'll check labs such as a uric acid. X-rays also give us radiographic changes that we can see that can help us differentiate this in comparison to other kind of arthritic changes. We have ultrasound, which is a wonderful modality that can actually help us see gout crystals. But the most important test, if I ever have a new patient and they're coming in for a gout flare, even if I'm convinced, I always love to try and take the fluid out if I can, if it's really swollen, because that's how we can actually send it to the lab or check under a microscope for gout crystals. It's really amazing because, it gives us a diagnosis right away. So risk factors for gout include diet. So in particular, red meat, shellfish, alcohol, especially beer, are my big, gout no-nos. So always, be mindful if you ever have any pain after eating these types of foods or drinking these beverages, if you have a flare, that could be related to gout. Any kind of trauma or surgery, basically anything that's causing like a acute change to your body or a stress to the body, like starvation, dehydration, any kind of illness that can trigger a gout flare. There are certain drugs that are also involved. We call them diuretics, so fluid pills such as Lasix or hydrochlorothiazide. And then a very common risk factor is actually kidney disease. So if you or anyone that you know is having joint pain and flare-ups and they have kidney disease, it would be something to consider. Gout would be something to consider. And then unfortunately, when I have very young patients that have really bad gout flares, I always think about genetic mutations, unfortunately, that can happen and cause gout at a young age. So if someone's like in their 20s or 30s, it's not common for us to see, but then I think of genetic changes that might have caused them to have gout. So treatment, we have so many different options for treatment. I really love, in general, diagnosing and treating gout because patients have such an improvement in their quality of life when they go on the proper regimen. So our most common medications, they all help us get rid of this uric acid crystal in our body in different ways. The most common one that I use is something called allopurinol. It's a medication that we slowly bring up depending on how patients are responding. Colchicine is another good one that's very good to use, especially if you have an acute onset. So that helps with the inflammation. And then oftentimes we also have to use some sort of steroid, such as prednisone, to get patients better. If there's only one joint involved or it's a really swollen joint, then we recommend taking the fluid out and injecting the steroids. And then ice is everyone's friend in gout, so it really helps with the inflammation as well. So if you ever feel like you're having a gout flare, it's really important just to try at least some home remedies, which would be ice. Tart cherry juice does have some data behind it that it might help with gout inflammation, and then low-fat dairy products have also shown to be beneficial for gout. Next, I'll briefly touch upon pseudogout. So I always consider this almost as gout's cousin. So it has a very similar presentation. The way that we differentiate it is that when we actually take the fluid out and look at it under a microscope, there's different type of crystals that are involved in comparison to gout crystals, which are monosodium urate. So these ones look different on microscope and they help us to really it's very important to try and differentiate if we can, because even though treatment is very similar, it's there's a couple different options that we have for pseudogout. Next, I wanted to talk about polymyalgia rheumatica. So this is a condition that I also love treating because sometimes patients will be told that they have osteoarthritis or they have some other kind of arthritic condition, but it turns out that they've had symptoms very suggestive of what we call PMR. So PMR is a disease that causes widespread stiffness and aching. It tends to come on rather quickly. And most patients will say that they woke up, from the middle of the night and they started having significant pain and stiffness in their shoulder. So they were having trouble raising both of their arms, and they were also having pain in their hip and pelvic girdle region, with once again significant stiffness in the morning. Hands and wrists can also be involved. And most patients will notice that their symptoms are worse in the morning and it slowly improves throughout the day. This is a systemic disease, so it can cause other symptoms such as like a mild fever, generalized fatigue, and sometimes weight loss. So we usually diagnose this disease based on the history. So I really try to take the most amount of time I can to get a good history of what's been going on. And then we also have labs that are very helpful. So we use markers of inflammation that's called the SED rate and C-reactive protein. They tend to be pretty abnormally high in these patients. And so they're very diagnostically helpful for us to gauge if this is PMR. And then we also sometimes will do further imaging or ultrasound to look for inflammation. So bursitis is inflammation of the bursa, for example, the elbow bursa or the shoulder bursa. So really in PMR, we look for shoulder bursitis. And then we also look for synovitis, which is another term for inflammation within the joint. So treatment for polymyalgia rheumatica includes the mainstream treatment, although we have newer options now, which I won't go into too much, is prednisone. So most patients that have this diagnosis might need prednisone for 1 to 2 to 3 years, and they have a significant improvement on prednisone. So it's like day and night. So they'll present with severe pain, start prednisone, and feel dramatically better over the next several days. Next, I can't be a rheumatologist if I don't talk about rheumatoid arthritis. So, rheumatoid arthritis is the most common cause of autoimmune inflammatory arthritis, and it can affect a variety of different patients. In particular, women are mainly affected. So, over 75% of patients that have rheumatoid arthritis are women. And that means that over 1% of women may get rheumatoid arthritis in their lifetime. We can see symptoms present around a pretty big age group, but usually we tend to see it in younger patients in their 20s or 30s, and sometimes, yes, we'll see it, in later on in life too, but it's usually seen around patients age 20 to 60. And rheumatoid arthritis, once again, the reason why we call it an autoimmune arthritic condition is because the whole theory about why people get it is because the immune system is attacking the small joints, in particular of the hands and feet. So over here, as you can see, these are the MCP joints of the hands, the knuckles look very, very swollen and inflamed, and you can see a little bit of curvature of the fingers here. We call this ulnar deviation. This is a classic rheumatoid arthritis hand. And then hammer toe changes of the feet are really common to see in patients with RA. So this is another disease. So most inflammatory diseases especially can cause significant stiffness. So as I had brought up in osteoarthritis, most patients will have stiffness for about 15 to 30 minutes. Rheumatoid arthritis patients can have stiffness last from 1 to 2 to 3 hours or most of the day. This is another condition that's very systemic. So some patients will present with like low-grade fevers, loss of appetite, weight loss, fatigue, very commonly dry eyes and dry mouth. Sometimes they'll have other types of eye inflammation, and it can also affect other organs. So for example, some patients have rheumatoid arthritis and also unfortunately lung disease related to RA. So it can be very challenging in some patients. We also use the most important thing that we do to diagnose is get a really good thorough history of the exam. So our rheumatologic exam is so incredibly helpful to help to differentiate different types of arthritic conditions, mainly because we look for different signs of swelling and autoimmune swelling, which is, once again, the term that we use is synovitis. So the exam and history is really important. And then we have labs that are helpful. It's not to say that labs will always diagnose it. I oftentimes will get patients that are referred to me because they have abnormal labs, but they may not have rheumatoid arthritis. The labs that are checked, if there is a suspicion, is something called a rheumatoid factor and a CCP antibody. Once again, sometimes this is positive in patients that have RA. Sometimes it's negative, and sometimes these labs are positive and they don't have RA. So it's really kind of the first two things that we look for, the history and exam, that help us. We also use inflammation markers in this disease. So the cytokine and C-reactive protein are really common tests for us to check in a multitude of different arthritic conditions. Some patients might present with low blood cell counts, known as anemia. And then we also love to get images. So here on the right side, you can see radiographs of the hands, which is very different from osteoarthritic hand changes. And so rheumatoid arthritis, unfortunately, causes narrowing and cystic changes, and that affects kind of we call these the carpal bones. There's erosion, so long-term inflammation changes can actually cause erosions of the bone. So whereas osteoarthritis is causing bone spurs, this is kind of breaking down bone due to inflammation. So, and then lots of narrowing of the joints, as we can see here. So treatment has it really revolutionized how we treat patients with rheumatoid arthritis. There's a variety of different combination therapies, monotherapies that we use. I listed a few here. Some of them are oral medicines, some of them are injectables. Once again, we've really changed the prognosis of this disease, where at this point in time, if we diagnose it early and treat it early, most patients have a significant response and improvement in their day-to-day life. So just to summarize, I wanted to go back to what a normal joint looks like. So you can see healthy cartilage, healthy bone, nice joint space here. We're gonna go right over here to the right for osteoarthritis. That's when you have extra bumps. So you have bone spurs that we call osteophytes, along with narrowing. And then rheumatoid arthritis, as I had mentioned, actually causes erosion. So it's almost chewing out at the bone, as you can see. So you have bone loss here, which is an erosion. And then there's, if you see swelling from rheumatoid arthritis, because this whole joint capsule, the synovium, which is the fluid that makes up that membrane, is thickened. So bone spurs, bone loss, thickened synovium here. Next, I call psoriatic arthritis a very distant cousin of rheumatoid arthritis. It's also an autoimmune inflammatory arthritic condition, and it can affect up to 30% of patients that have psoriasis. So if you ever know someone who has psoriasis and they're having joint pain and swollen joints, it's really important for them to see a rheumatologist. It can also affect any joint in the body, just like rheumatoid arthritis. Oftentimes patients will have what we call sausage fingers, which we call dactylitis, swelling of the knee. It can also present with low back pain and affect very specific joints of the low back that we call spondylitis. And then there's patients that can have pain, for example, in the ankles or different areas, which we call enthesitis, and that's basically pain where tendons and ligaments may attach to bone. Genes do play a role in this, and this disease can affect both males and females equally. So here's a picture of a swollen ankle right here. This is what we call enthesitis due to psoriatic arthritis. Here is a sausage toe and a sausage finger that we call dactylitis. And you can see the overlying psoriasis changes there. Psoriatic arthritis is another systemic condition that can cause inflammation in different areas, in particular the eyes. So one of the questions I always tease out in my clinic is if a patient's ever had something called uveitis, which is inflammation that can affect a patient, cause redness and pain in the eye, and it's usually treated by an ophthalmologist with steroid eye drops. And another clue for me as a rheumatologist of whether or not a patient with psoriasis has true psoriatic arthritis is if they have nail disease. So that oftentimes gives us an idea that they might have psoriatic arthritis. And as you can see here, these are nail pits that can be seen in patients that have psoriasis and psoriatic arthritis. So that's something that I always like to take a look at our nail features. I'll briefly talk about ankylosing spondylitis for the sake of time. This is a condition that can cause significant pain, especially in males of a young age in their 20s and 30s, due to inflammation of what we call the sacroiliac joint. So here is an image of the sacroiliac joint that looks normal here. So what happens with this disease is there's inflammation, as we can see with this extra shininess, which we call sclerosis. There's erosions that can happen, pseudo widening, so many radiographic changes that we look for. But basically what it tells us is that there's inflammation of the sacroiliac joints. And that's an autoimmune process with also genetics involved that can cause a lot of pain, stiffness, and swelling. Most patients, once again, are males that have low back pain that's really stiff in the morning and gets better with activity. Here's a diagram just to show what a healthy spine looks like. So this is a vertebral body, kind of like our backbone. Here are discs, and they all look nice and healthy. They have a nice smooth curvature. What happens in ankylosing spondylitis is unfortunately what we call a bamboo spine, where these vertebral bodies start fusing together. And this is all related to inflammation at this space that causes long-term this type of change. Symptoms, once again, is low back stiffness that gets significantly better with activity. Sometimes patients will say they have alternating buttock pain and nighttime awakening with back pain. Once again, very classically, especially in a younger population, these are all concerning features and they should be seen by rheumatologists. Treatment for this includes anti-inflammatories. Oftentimes, however, we'll have to put patients on what we call biologics, and there's a variety of different medications that have been approved to get this disease under better control. In particular, we have both injectables and we also have oral medications that work well for this disease. And now lastly, I'm going to touch upon Lyme disease, a very common question that I get in my clinic of do I have Lyme arthritis? So Lyme disease results from having an infection from a bacterial organism which enters through certain infected tick bites. And this is a very prevalent area to get Lyme disease. So it's something that we should always be thinking about. There's different stages of the infection. Most people will have the localized bullseye rash, as you can see on top here. And then later on, when they have early disseminated disease, they'll just feel achy and have a lot of malaise, fever, muscle aches, joint aches, headaches, sometimes heart involvement. And then that's, once again, that leads to the workup and diagnosis of Lyme's. However, it's not very common to have Lyme disease and always arthritis. So Lyme arthritis is usually seen more so late stages of like untreated or undiagnosed Lyme's. Oftentimes it'll present with a swollen knee. For some reason, Lyme's really loves to cause a unilateral swollen knee. So what I mean by that, as you can see in this diagram, they'll have a really swollen, fluid-filled knee. We'll take out the fluid. If we have a high gestalt for Lyme disease, we'll check the fluid for Lyme, and that's how we do the workup. And then also later on in late stages, this is once again months later, patients can also have nervous system involvement with numbness, tingling, and weakness. So these aren't the most common things to see. Most people will stay kind of in this early localized or disseminated stage. Late stage is always, on my differential, if I have, for example, like a young patient with knee swelling and it's recurrent even, after I take out fluid and it keeps coming back, then I have to think about things like Lyme disease or other infections. There are other infections that can cause arthritic conditions, which I just spared everyone to discuss, but Lyme just happens to be one of the infections that's commonly also associated with joint aches. So I briefly touched upon during this whole lecture when to see a rheumatologist, but re-emphasize if you have exquisite stiffness, especially in the morning, that improves the activity. That's a really good time to see a rheumatologist to see if you have like an inflammatory arthritis. If you have really swollen joints, especially in the knuckles or feet, or a history of psoriasis or a strong family history of autoimmune diseases, whether it's RA or some other autoimmune disease, it's always good to be seen by a rheumatologist. And I didn't talk about this as much, but if you ever know of someone who has inflammatory bowel disease, so ulcerative colitis or Crohn's, and they have joint pain, it's also really important for them to see a rheumatologist, as oftentimes there can be overlapping or associated conditions. And so these are some resources that I just wanted to talk to you about. So I use a lot of YouTube for home exercises, which I highly recommend. Please make sure that it's exercises that are recommended and done by physical therapists. Tai Chi is good for almost all the variety of different kind of joint pain syndromes. Strength training is really important for bone health. A healthy diet, this is a common question that I get, I think is ideal for anyone. So a Mediterranean diet with anti-inflammatory foods such as berries is really good for you in general, and it may offset some joint pain. And then arthritis.org and Creaky Joints are some of my favorite websites that have lots of information about the different kinds of arthritic conditions. And that's all I have for you guys. So thank you so much again for having me. And I really hope that I was able to shed some light on at least a few different type of arthritic conditions. And I'm always happy, just for the sake of time, if we don't get to all the questions, uh, to message you guys, and happy to see you in my office after I have my baby. I'm due within the next month. And I come back in October, but I'm happy to go over any questions if anyone has any.
All right, thank you so much, Dr. Khawaja. We have tons of questions that have come in, so let's see how many we can get through.
Sure, let
Um,
me see. I think I have roughly, I'm so sorry guys, because I haven't
yeah,
have to round in the hospital too. So I'll try to get through them, at least a few if I can. So bear with me.
yeah.
Let me open up this chat.
All right. I have one that was emailed in a couple days ago in
Yeah, sure.
anticipation, but
Sure.
is there any way to help slow arthritis in their hands, and are there measures we can take to minimize the progression?
That's a great question. So my answer would be it all depends on what kind of arthritis of the hands it is. So Osteoarthritis is such a common question that I get of, Doc, I have hand osteoarthritis. What can I do to slow the progression? There isn't a lot of data on it. So we've looked into, many great researchers have looked into what can we do to slow the progression. And the data has just been so variable. So there's really, unfortunately, not something there to slow the progression, aside from actually really building strong muscles. Once again, if there's anything that's going to help, is building strong muscles to offset at least the pain. But a lot of these conditions, as I may have mentioned, is a lot of it is a genetic predisposition. It's with time, with age. So in a very vague way to answer that question, depends on what kind of arthritic condition it is. If it's rheumatoid arthritis, the best way to slow the progression is medicines. For osteoarthritis, unfortunately, we just don't have one medicine that would slow the progression.
All right. Um, you talked about this, but are there any vitamins or supplements or foods or spices that are both harmful and helpful?
Yeah, so that also depends on what kind of arthritic condition there is. So for everyone, I always recommend following like a well-balanced Mediterranean diet with anti-inflammatory foods. There is a diet that was researched or at least is being looked into for rheumatoid arthritis called the ITIS diet, the ITIS, which I use for almost all my patients just because I really believe that it helps even with, cardiovascular risk factors. So I do recommend a Mediterranean diet for almost everyone. In terms of supplements, so there's been, they've looked into glucosamine chondroitin, and it is so controversial in osteoarthritis. I usually don't, I kind of stay indifferent actually when my patients tell me. So if you have it and you try and you feel like it's helping you, that's fine. But unfortunately, the data is just not convincing enough that it's beneficial that we should put it into our protocol. So what I usually say is, get it through your diet, like, just have a well-balanced diet. And if anything, you can take a multivitamin, but you don't have to go out and buy any of these supplements because it is so variable, and I can't really recommend them because the data is just not there to be as supportive as we'd like. Oh,
Is
my
that
apologies. And for patients that have like an inflammatory arthritis, I always get questions about turmeric, which can be beneficial. So turmeric, ginger, adding that to your diet, adding that to your food, I have zero objections to because it might help offset inflammation. For gout, I had briefly touched on like having a low-fat dairy intake is tends to be beneficial. Omega-3 fatty acids tend to help with patients with rheumatoid arthritis. So it all once again depends a little bit more about what kind of arthritic condition you have, but otherwise I would say like an anti-inflammatory Mediterranean diet is a great thing to follow.
is degenerative joint disease considered arthritis?
Yeah, so when they say degenerative joint disease, oftentimes they're really referring to osteoarthritis. I just hate that terminology. I don't even use it because it just makes people feel like once again it's like wear and tear and that it's all age related when it's not. So if you see those terms on, for example, like an x-ray that you had, or someone else is telling you you have degenerative joint disease, most likely once again it's more so they're telling you that you have osteoarthritic changes.
What are some of the common causes of osteoarthritis that causes the things to break down?
So the risk factors, once again, is there there's a whole slew of things that happen at a microscopic level, which I will save everyone, but there is, a little bit of inflammation involved. There's different like degradation pathways that happen. But there's unfortunately a lot of patients that have it. The risk factors include age, genetics, sometimes trauma, sometimes overuse injuries can cause it. I hope that answers your question. So there's a lot of risk factors and there's different changes that happen at that level. But there's no one thing of this is, for example, there's environmental factors that might be playing a role in a lot of our arthritic conditions, but no one clear thing. It's tends to be a multifactorial change that happens in osteoarthritis.
All right. If a grandparent had the nodes that you were referencing before, how likely is it that the grandchild to get it?
That's a great question. So, Osteoarthritis, once again, very common for most people to get at least some changes with time. It's a higher risk. I can't give you a percentage because it all depends on the degree of uh, changes that the grandparent may have had, but that would be definitely a higher suspicion for that person to get it, but it would be a gradual change. And it's usually more so in the 60s, 70s that you might start noticing a little bit more bumps of, for example, your hands that might look, later on more like a grandparent. So there's a higher chance, especially if you have that. So I always have my patients, for example, that come into me for hand osteoarthritis, think back to what their grandparents' hands look like. And unfortunately, I do mention that, over time their hands might start looking like that as well. But everyone is varies, but higher chance. I don't have like a good percentage of how the degree of those changes that a patient might have or a person might have, but there is a higher chance of having similar changes.
I'm going to pronounce this wrong, but does Sjogren's,
Sugar,
Sjogren,
yeah, yeah.
or fibromyalgia cause arthritic-like symptoms? And are either of these treated by a rheumatologist?
Yeah, so that's another great question. So I actually shied away from talking about lupus and Sjogren's because there's so much involved with that. But yes, patients that have Sjogren's can have joint pain and stiffness and swelling, and it all depends on how they present. Sometimes we have to use medication similar to lupus patients for Sjogren's patients. Fibromyalgia is not necessarily a joint pain condition. And it's also not an autoimmune disease, but it can cause joint aches and usually muscle aches, and patients tend to have multiple different tender points. Oftentimes we're happy to, if someone has pain, right, and it's they have any suspicions for one of these diseases, whether Sjogren's, fibromyalgia, I always recommend getting at least an initial consult with a rheumatologist to help direct and work up the pain. And then sometimes fibromyalgia will be co-managed by a primary doctor, or sometimes we will manage it. But I do think that if you have any of those symptoms, it makes sense to see a rheumatologist.
The crystals associated with gout, are they always in your body at some level? And I guess they would fluctuate.
So they usually fluctuate, but our goal is to keep the levels down so they don't become symptomatic. So it's normal for our body to break down and make uric acid, but it's not, the goal of the treatment and the goal of management is for it to be at a very low level so that patients don't have flare-ups.
Are there any new injections for the cartilage for treatment rather than
There's
the traditional
always
gel?
new injections. I don't always recommend that, mainly because if they have weak data, I oftentimes get questions about gel injections or PRP, and the data is just once again not always the best. Although some other specialists might disagree, but we really do prefer, the injections that we use that have been around for a very long time are steroid injections. So that's usually what I always recommend using in my office is dirt cheap. They tend to have, at least, we have a protocol that, yes, they tend to be more so preferred in patients with osteoarthritis and inflammatory arthritis. But let's say if a patient didn't have a great response or they want to try gel, I may consider it, but they just don't have still the best data in comparison to even like a steroid injection. So I don't oftentimes use it. And yes, there's so many different injections that are out there, but I tend to shy away unless we get really good, robust clinical data that supports it.
Um, what about osteoporosis? Does that have anything to do with arthritis? And what can you do about it?
Yeah, great question. So the answer is no. So osteoporosis is a condition that causes low bone mass, but it does not cause any kind of joint pain or bone pain. Unfortunately, patients who have osteoporosis can have an increased risk for fracture. So that's why we always love to, once you qualify, get a DEXA to see if you have, or also known as a bone scan to see if you have low bone mass. Patients that have osteoarthritis can have osteoporosis, especially postmenopausal females can have osteoporosis. And once again, our goal is to prevent something like a hip or a compression fracture, but it is completely separate from osteoarthritis.
Does having scoliosis make you more likely to get arthritis?
So scoliosis can cause more back pain, back issues. back arthritis. It all depends on the degree. Some people have a very mild form of scoliosis and they might have, once again, back aches because of posture issues or joint issues. But if it's mild, I don't necessarily say it's going to worsen osteoarthritic changes, which might be happening anyway, but it all depends on the degree of scoliosis.
Um, does having gallstones or high purine levels increase the likelihood of getting arthritis?
So if you have high purine levels or a high purine diet, I would definitely be concerned for gout. But having gallstones in itself, I'm actually not sure if that would be at all associated with any particular arthritic condition. So they're two different things, but a high purine can cause increased risk for high purine diet, increased risk for gout. Any other questions? I think I can take one more if there is one more question.
All right,
I think
let's
we've covered
see.
it.
All right. Can any of these cause numbness in the feet?
Uh, any of the arthritic conditions that I
Yes.
described? So sometimes, yeah. So if it's like an inflammatory arthritis, for example, if you have really swollen joints, it can compress a nerve, and that's usually what causes neuropathy, which is numbness and tingling. The most common cause of numbness and tingling in the feet, unfortunately, are diabetes, especially uncontrolled diabetes. But numbness and tingling usually more so are related to nerve issues. But can arthritis cause it? Yes, especially if it's a really, really swollen joint that's compressing a nerve. So it'd probably be good to see your primary, see your rheumatologist if you need to, and then if that workup is negative, for example, if you're not having a lot of joint pain with the numbness and tingling, really should be managed by a neurologist.
All right. Well, thank you so much, Dr. Khawaja, and thank you everybody else. There are still a few more questions out there, but I'm going to give you Dr. Khawaja's email so that you can email her directly and she'll be able to help you with that. So I really appreciate all the information you shared today and everybody for attending. I hope you found it very, very informative.
Yes, thank you so much for everyone attending. I really hope this was helpful. And once again, I'll be happy to answer any questions via email. And I wish everyone the best. Thank you so much again, Andrew. I really appreciate it.
All right. Thank you. And thank you everybody for attending again. Everybody be safe, be well, and hopefully we'll see you soon.
All right, take care, guys.